Thank you, everyone. I appreciate that. I think I need to update my bio because I hate to say it, but it's well over 30 years now. But that's okay. A long time doing this. Absolutely love what I do. I noticed I went through the participants' names there and I recognize a few names in there. So welcome, everyone. So today we're going to talk about blocking that pain and helping our dental patients not feel all that pain, whether they're under anesthesia or recovering from it. Now, we know that unfortunately, many of our dental patients are at risk. Most time they're still older patients because, a lot of practices still consider dentistry an elective procedure as opposed to being a preventative procedure, which it really should fall into that category. And we just don't always put enough emphasis on patient safety. I always kind of start this discussion with if we had two patients, one of them being a 6-month-old golden retriever in for an ovarian hysterectomy or a 12-year-old Yorkie, um, and for a dental procedure, which patient, if you only had one anesthetist, who's going to get the anesthetist if they're scheduled at the same time? And the correct answer is they both get an anesthetist, no questions asked. Um, but a lot of times I get the answer, it's the spay, and it's because it's in the surgery suite is the answer I get. Well, that 12-year-old Yorkie is a much higher risk probably than that golden retriever is. So we need to make sure we're really taking care of our dental procedures and our dental patients. We want to make sure we're minimizing the risks as much as humanly possible. So I like to do something we call surgical safety blood work. It's a warm, fuzzy name for pre-anesthetic blood work. Just puts a little bit more, kind of that warm fuzzy for the pet owner when we say surgical safety. An older patient who maybe have a comorbidity, we probably should also do an ECG. Always do a full physical examination. And then we need to really start customizing our anesthetic protocols. The days of every patient getting cat val are gone. And there's so many other things we can use that are so much better for our patients, as well as, and I cannot stress it enough, that dedicated anesthetist, that constant monitoring. Don't expect your dental technician or your person doing the procedure to stop every 5 minutes and take a set of vitals because it will extend the time of that patient being under anesthesia. And I know we're all shorthanded. I get it. I understand that. But we really need to make sure we put that emphasis on our dental patients. So when we look at definitions, anesthesia is the absence or loss of sensation. Now, when we do a dental procedure, we really do want our patients to be at a surgical plane of anesthesia where they have muscle relaxation and obviously analgesia. And analgesia just means they're not feeling pain. So that's what we're really wanting to have when we do a dental procedure. We know that pain is inevitable, but suffering is optional. Anybody in the audience, and we don't have to raise hands or do anything, but just think to yourself if you've ever had any type of dental procedure done, whether it's a root canal or a filling or whatever else, it can be painful. And we're not always asleep for that, but it still can be painful and it can be painful afterwards. So we want to make sure that our patients, are being taken care of and not feeling that. So we're going to do a brief review of the nociception pathway just to kind of help you understand how pain works. And nociception is actually just the perception of pain. And we know now that animals basically have the same anatomical structures and mechanisms in that we have as humans. So basically what's painful to us is painful to our animals. I mean, I'm an old farm girl, grew up on a dairy farm in Minnesota where our vet told us all the time that animals didn't feel pain. There's no reason to ever give them anything for that. And I'm like, that, those days have changed because animals do feel pain. What happens when you clip a toenail too short, guys? The dog yelps because it hurts. Okay. So yeah, pain, what hurts us is also going to be painful to our pets. So with nociception, there's three different distinct physiological processes, and we're going to go through each of these kind of quickly, but we have transduction, transmission, and modulation. Now, transduction is basically the site of the injury. Okay, that is where it's translated into physical energy, into electrical activity, and it's going through the peripheral nociceptors or no nociceptors. So we have receptors such as mechanical pain, chemical pain, or thermal. Mechanical is going to be an incision. Okay, you cut yourself, you have an incision, that's mechanical. Chemical is, I always kind of joke about it, and hopefully nobody's using this anymore. But the old cold sterile packs where you're digging through a bowl of cold sterile to find an instrument, and you had no idea you had a paper cut, and you find it when you're in that chemical because it burns. And then thermal, of course, we've all had where we touch a stove, right? We touch something too hot and we have thermal injuries. Now, that is at the site because that's where all those sensory nerve endings are. Now, transmission is as those nerve impulses move through the nervous system, because we have the impulse, it's going from one synapse to the next, to the next, to the next. Okay. And everybody has stubbed their toe at some point in their life, some of us more than others. And we have that.
Mary, I think your Wi-Fi froze up. Hi, everyone. Bear with us as we work through this technical difficulty.
Hey guys, I am so sorry. We had a little glitch here in our electrical system and I got booted.
Oh,
Give
okay.
me just a second to re-share my slides here.
Sounds
I
good.
kind of thought, was I blinking or was the lights flashing on me? So hold on. All right. So now the next stage in all of this after transduction and transmission is going to be modulation. And that's where all the little synapses have gone to our spinal column. Okay. And then as it goes through the spinal column, we're going to have it move up to our cerebral cortex. And that's when we feel it. Okay. That's when we have the ouch, that really hurt. And it only takes a few split seconds, like portions of a second for this to happen from start to finish. So that's when we have a result of successful transduction, transmission, and modulation. So just to review, transduction is the site of the injury, transmissions, the sensory nerves connecting to each other and the little synapses. Modulation is moving through the spinal column, and perception is in the cerebral cortex when we feel it, when we recognize it. So, what are the consequences to pain? Well, we can have pathological pain, and pathological pain happens when, when we have a patient who's extremely painful, they're going to be at a greater risk for infection. Their wounds aren't going to heal as fast. They may not want to eat or drink. They're not getting that important nutrients to help heal themselves. Some will become immobilized, and some may be more restless. They're going to have altered sleep patterns. They can't get comfortable. They don't want to sleep, or they sleep all the time. And then we can have altered behavior patterns. So we all know when we're looking at pain recognition that we can have physiological signs as well. Anybody who's monitored anesthesia during a surgical procedure kind of knows the old crank up the anesthesia sign, right? Because when the doctor's getting ready to make the incision or pull a tendon or do something, the heart rate goes up, the blood pressure increases, we start getting vasoconstriction and increased respiration, because this is now, even though the animal's under anesthesia, they're still having a physiological reaction to the pain. And then we can also have, again, I said it earlier, reduced appetite and food intake. Sometimes they don't, void like they should. They may, void in the kennel or not use a litter box, and they may have reduced grooming. Dogs and cats are different in their pain recognition. Dogs will sometimes whine or whimper. There's a few dogs out there that are true, stoic. I'm not going to let anybody know I hurt. And then there's the prima donnas who whine a lot. But a dog, when they're painful, will be very timid or become very aggressive. And I've seen this in practice, when we had the sweetest dog in the world, went and had a TPLO at another practice. She came back to us for follow-up. She was a completely different dog, totally aggressive to us, like somebody had just flipped a switch in her after her TPLO surgery. A dog, however, will just have usually a fixed stare when they're in pain. They're just going to kind of fixate on something and they're very, very restless. They can't get comfortable. So back in the day, and hopefully we're not doing this much anymore, but back in my day, a patient was in the hospital overnight on an IV line, and you come in the next morning and it's all tangled, especially in a dog, because they've kept getting up and moving because they can't get comfortable. Now, cats will purr, growl, or groom when they're painful. Yes, they will purr. Purr is a way of calming themselves down. A cat will, however, will hide. And that is really important with our dental patients, that we have that conversation with the pet owner when the pet goes home, that we want them to check on their patient a couple times a day at least to make sure everything is okay. Don't let them just go, hide in the top of the closet, and you haven't seen them in 3 days. So we don't know if they're eating, drinking, or doing anything they need to do. But a cat will squint. They just don't feel good. They look a lot like this cartoon cat. And a cat who's painful is not going to move very much. Now, hopefully, most of our practices now are using pain assessments. And there's a lot of different options out there for pain assessments. And it's really important, if you can, to know what's normal so you can kind of watch the patient from a distance. Maybe they're a patient you've seen, so you kind of know what they're going to be like. You can have an interactive evaluation with them and then record those findings using an assessment tool. When you do these types of assessments, make sure that you take the time to train your team so that everybody is calling, a 3 Okay. And we all know what we're looking for. This is probably the most common one out there is the Colorado State um, uh, pain assessment. There's a dog one and a cat one. Excuse me. I think the ones that are the most fun for me now are the grimace scales. I think they're just kind of fun to look at. They have grimace scales. They started actually in research in rats and mice to determine pain levels. But now they have they have grimace scales for donkeys and goats. I know someone who's working on the goat grimace scale. The only one we don't have at this point is dogs. And I asked one time why we don't have a dog grimace scale, and it was because dogs' facial expressions don't really change that much. And I was reading an article this morning that said, dogs through domestication and selective breeding, we have kind of removed their facial expressions compared to what the wolves have. So it was kind of an interesting article. But I love this one. This poor cat here on the left of your screen. There, that cat's on. Like he just had some catnip. He's happy. He's bright-eyed, bushy-tailed. He's ready to go. He's just as happy as can be. We know the middle one isn't feeling too good. We're starting to squint. Our ears are kind of pulled apart a little bit. Our muzzle is tense, and obviously the one on the right is painful. That is a cat who is just not feeling well at all. So now we're here to what we really want to talk about is pain management for our dental patients. Now, I'm a big believer that I know there's always going to be a risk when we do some pain management, but I am fully believe that the benefits outweigh the risks every time. Because man, the first time I placed a nerve block, I was never so happy in my life because it was in a situation where we were doing canine extractions on fairly quote unquote healthy teeth. I placed a block and I was able to maintain that patient at less than 1% isoflooring through the entire procedure. That's when I became a born again. Everybody's getting a nerve block, guys, because I absolutely was amazed. It wasn't cranking that anesthetic up to 5, to keep them quiet. Now, there's strategies for pain management, and some of that's going to start well before the procedure. And multimodal analgesia is really what we want to look at. It's more than kind of the new or newer word in the veterinary jargon, but we really want to use two or more different classes of drugs and different techniques so that we're inhibiting that nociception pathway. So we're getting it at transduction, at transmission, and when it reaches modulation. So we want to look at balanced anesthesia, and that's going to sometimes require multiple drugs. And when we use multiple drugs, we're going to minimize the drug effects, but maximize their benefits.
Apologies, everybody. It looks like she got booted off again, so we'll give her just a few moments to get logged back on. Hi, everyone. Give me just a few minutes and see if I can get a hold of Mary through a text message. Apologies for the delay.
I have no idea what just happened there. My laptop just shut down. Sorry about that, everyone.
No, all good.
Um,
We can see and hear you loud and clear.
and can you see my screen or not yet?
I still see you.
I swear it's beautiful and sunny here today. I don't know what the problem is, but something's not working right in the universe. Hold on just a second.
Gotta love technology, right?
Yeah, it works great and it works. Okay, come on. There we go. Okay, so when we look at the balanced anesthesia, we really want to maximize the drug benefit, minimize their effect, and we need to tailor those to the specific animal. I love to use pre-medication and sedation drugs to not only kind of help reduce pain earlier, but also to relax that patient, relieve some of their anxiety. When we look at balanced pain management, we're going to prevent inflammation and wind up. And wind up is when we kind of wait too long to give medication. It actually takes more of it to actually be effective. So we want to be kind of proactive in that situation. It's like if you wait too long when you have a headache and you wait too long to take medication, and pretty soon you have to take twice as much Tylenol to kind of help with the pain. Whereas if you took it right away, it'd be a better situation. When we look at doing that, we do the balance, we're going to not lose the efficacy of the drug. And it's going to make sure that we suppress those neuroendocrine stress responses. And it actually shortens the convalescent time and helps with tissue healing. Now, opioids are one of our most common pain medications out there. Yeah, I know there's, some talk out there about trying to decrease the amount of opioids being used in veterinary medicine for multiple reasons. But I think they're still a good choice for most of our patients. Um, they're going to react specifically with the receptors. Now, the type of opioid you use is going to be up to the veterinarian. You do have to know the side effects of these opioids, and they have to be constantly monitored. Now, there are some poor choices for severe pain, and a surgical extraction of a tooth is severe pain. You're removing bone, you're cutting tissue, you're removing bone, it's painful. So, butorphanol is probably not the best pain medication out there. It's not very strong, and it can actually block other opioids effects. I always kind of tell people that, using just Torb is kind of like, throwing aspirin at a fractured femur. It's not going to do a whole lot to help with that pain. Another one, when I was in practice, I used it all the time, buprenorphine. Everybody got buprenorphine. And we know now that it can actually block other opioid effects. So, is it as strong as we'd like it to be? Probably not. We can use it to increase the longevity of some of our regional nerve blocks. And I'll talk about that a little bit later. There are some over the, more extended release buprenorphine injections out there. Cimbadol is out there. Another one that I like is Zorbium. Had a grandcat that came home from a orohematoma and was on Zorbium. And let me tell you, I was ecstatic. I did not have to dose that cat because she was not happy with us at that point. Good choices for severe pain are going to be things like our pure mu opioids, our hydromorphone. We do need to know that it can cause hypothermia and dysphoria in cats. Methadone, great option for kitties. Morphine can have some heavy sedation and some allergic reactions, and we don't want to use it in cats. If a patient's going to have some severe work done, say full mouth extractions, maybe a fentanyl CRI might be an option. The nice thing with opioids is that we can reverse them with a naloxone if we need to. So we want to do that preemptive analgesia. We want to avoid the windup. So some of those things, like I said, are opioids, alpha-2 antagonists, and NSAIDs. We know we're never going to eliminate all postoperative pain, but there's no reason that patient has to suffer either. Okay. So, again, the preoperative ones are going to be the opioids. We don't want to use them with someone who has intracranial pressure, decreased heart rate, increased temps in dogs. I just had to keep this slide in here because that little girl was so cute. I always say she had one eye looking for you and one eye looking at you. In preemptive analgesia, we're going to make sure we're giving it prior to the procedure, usually somewhere around 20, 30 minutes before the procedure. These are going to be things like midazolam, diazepam, acepromazine, dexmedetomidine. These are going to have a more profound effect when they're used with an opioid. And they kind of take that anxiety level off of that patient as well. Now this is really what we talk about, right? We're here to talk about the local anesthetics. These prevent that conduction, okay, as it's going from one synapse to the next. We can use anybody in the cane family. Now, there's some canes that are better than others. So, my drug of choice is going to be bupivacaine, 0.05%. Now, any of these drugs can have cardiovascular toxicity if it has gotten into the blood system. I've actually had this happen to me as a patient before I was in vet med. I had a filling done and the doctor blocked my mouth, and he comes back. He says, "I'll come back when you're numb." The minute he walked out of the room, my heart just started racing. I had no idea then what was happening. Now I know that he got that block into my bloodstream. Now, some of the advantages are, again, like I said earlier, placing a block, we can reduce that general anesthetic requirement. We don't have to do the old crank the anesthesia up. We can keep it as low as possible. And we're going to have prolonged pain management. So the patient is going to go home. They're going to eat that evening. The owner is happy because the animal's coming home pain-free. And it's just a better situation. There is nothing more rewarding than to have a cat with raging stomatitis and you do full mouth extractions on them. And because you've blocked all four quadrants, when they're awake enough, You offer them food, and that cat is eaten like they've never eaten, or at least in a long time, because they don't hurt anymore. Now, when it comes to nerve blocks, there are some contraindications. You don't want to inject directly through any really infected tissue. You don't want to take that infection and kind of draw it down into the tissue and maybe result in an abscess. And there's also side effects that cats can have self-mutilation because they may lose sensation of their tongue or lips. Now, knock on wood, in over 20 years of placing a block, I have never had this happen. Okay. So, probably going to happen sometime soon, but it hasn't happened yet. I know when I have a block, I talk like this so that I don't bite my cheeks because I know I can do that. Our dogs and cats don't know to not open their mouth. So one of the things that I find that really helps a lot to reduce this is the way I do one of the blocks, which we'll mention, but also to recover your patient in kind of an anatomically normal position where they're, so if you're, where their internal recumbency and their tongue is where it should be in their mouth instead of kind of lollygagging out of the side of the mouth. So that means that they're going to be less likely to chew that tongue if it's numb. Now, there's some patients who wake up and they're like, oh my gosh, I can't feel my face. They may need to have just a little bit of sedation for anxiety. And sometimes it is like a super low dose. I mean, like 0.000 mils of, dexmedetomidine IV, just the hub, to kind of take that anxiety off. Now, I will tell you that, first of all, if you had 10 people giving you a lecture on how to do nerve blocks, you're going to have 10 different ways to do them. Okay. You have to determine what you're comfortable with and what works best for you. Some experts are going to tell you to go all the way deep into the foramen with a needle. Okay. I don't do that. There's stuff in there. Okay. There's blood vessels, there's nerves, there's an eyeball. I'm never going to go into the foramen. I just go to the edge of it. And I'm going to do techniques that are going to still work to block the entire quadrant. So don't worry about that. This is what you need. You don't need to have anything fancy. You don't have to go buy one of the, block syringes that they use in human medicine. A tuberculin syringe, 1 mil syringe, 25 gauge needles, a lot of needles. I use the cover of a tray from vaccines as kind of my little prep tray for this. And I use the 0.05% bupivacaine. That's all I use. I don't mix lidocaine. I don't mix anything with it, just bupivacaine. And I use a lot of needles because we want a sharp needle every time I go make a stick. Okay. I don't want to use a used needle that might be dull. I also have this little, I guess, I don't know what you want to call it, but where I have to have two syringes because if I only have one, I'm going to need another one. Hyperstition, that's what it is. So here are my options for other drugs. You can use lidocaine. I'm not a big fan of lidocaine by itself because it is so short acting. And if we're doing anything too traumatic, I want to have something that acts a little bit longer than an hour and a half. It does set on very quickly. Mepivacaine's another one, ropivacaine. You can use articaine, septicaine, you name it, as long as it's a cane, it works. Just know the dosage. Like I said, I'm the 0.5% bupivacaine because it is the longest acting. Okay. Now we used to mix lidocaine and bupivacaine together because we had that rapid onset, 2 to 4 minutes, but it lasted longer with the bupivacaine. But studies actually proved that it really wasn't working. It was actually decreasing the efficacy of either one of the two drugs. Okay. So I stopped using lidocaine probably 15 years ago by mixing them together. And I've really been successful. I always kind of say, when you're going to need a block, get it on board as quickly as possible. And this is a technician skill with a technician who is trained to place blocks. They can do that depending on your state requirements. But have them get the block on board. And by the time the doctor's back there and ready to go, it's in place and ready to work. So the maximum dosage is going to be 1 to 2 mg per kg for dogs and 1 mg per kg for cats. Now, I tend to only use 1 mg per kg for both dogs and cats. Okay. I could double it if I needed to, but I do 1 mg per kg. And then this is where it really becomes important is how much am I going to use per site? So in a cat, I never go between more than about 0.1 to 0.15 mils per site in a small dog or cat. In a big dog, I might go to 0.3, maybe to 0.5 if it's a really giant breed, but I don't put a whole lot there because I know it's going to work. All right. And I always have a reserve then so that, if I need to give more, I have the option to do that. I don't want to give the full daily dose and then not have the ability to give more if I need it. Now, if you want longer effectiveness, and some of these reports go to 48 hours or more, um, that you could add buprenorphine to it. And that's going to be 0.003 megs per kg. So it's just a teeny tiny amount added to the Buprenex. Excuse me, not Buprenex. I'll get my words right. And then you could add dexamethasone if you need to at 1 to 2 micrograms per kg. There's no studies that really have proved this effective in dogs yet. Okay. We know it works in humans and rats, and I do know some people who are using it off label. So it is an option to try that as well. Always make sure you aspirate. I don't want you going into a blood vessel with this. And then also, while you're doing this, make sure somebody is monitoring very closely for you with the patient with this really old-fashioned type monitoring instrument that we use called a stethoscope. Have them listen to that heart while you're placing that block and make sure that we aren't having any cardiac reaction to that. But I always like to aspirate and maybe rotate the needle at least once and aspirate again so that I know that the bevel of my needle isn't up against a blood vessel wall. Okay. And that's going to help us eliminate that cardiotoxicity. If you draw back and you get blood, the best option is really just to start with a new syringe because you're not going to know next time if it's new blood or old blood. So that's why I always kind of have those 2 syringes available if I need it. Now you can do field blocks. These are going to be kind of like if you can't get to an area because of really infected tissue, you could block around an individual tooth. It's not going to be regional. It's not going to hit the nerves, but it will kind of deaden the skin around it. I do this sometimes for deciduous teeth, just to kind of make the pet feel better. They've already probably lost other body parts that day, so I want to make them as comfortable as possible by, kind of blocking for those deciduous teeth removals as much as possible. So what do we do? Well, step by step, I draw up my dose and I put a new needle on. I've taken that needle through that rubber stopper and it's gotten dull. So I'm always going to put a new needle on. I will then find my injection site, insert my needle, aspirate and rotate at least once, and then I'm going to inject, use digital pressure and gravity, and monitor that patient closely. Now, I have 4 blocks that we're going to talk about today. And I'm going to tell you that of the 4 blocks, I do 2 of them most frequently. And this one is probably the one I see most people want to use. I rarely use infraorbital nerve block because of the way I do it. It is only going to block my canines and incisors. It's not going to block any of my cheek teeth, okay? And sometimes I'm going to need that 4th or premolar or that 1st molar blocked. So I'm not going to use where I go into that foramen because, again, there's stuff in there. I will go ahead and palpate the caudal ventral margin of the zygomatic, it's of the foramen. And this is pretty easy to find on most of our patients. I take my 25 gauge needle. I go to the edge of that opening. All right. Then I'm going to aspirate, rotate. And after I've injected, I create a very technical term called a bleb. And once my needle is removed, I use digital pressure, pushing that medication into the foramen, and I elevate the nose a little bit so that gravity helps me do that. Of course, we have some pictures here. This is just a mock-up of the nerve system in a skull. I'm going, I don't know if you can see my cursor or not, but I'm going right here, okay? Going right directly over that missing 3rd premolar that's missing here. But right in there, I go right to the edge of it, and it'll block all these nerves forward, okay? So I can do it. This is a really long needle. I usually use just 7/8 inch or whatever. But I just go to the edge of it. Okay. And I'll use the dog's muzzle to kind of help support it so that I'm not moving around too much or jiggling too much. Another way that you can do it, and I had a attendee teach me this at a wet lab, that they do theirs like this. They come up from the bottom just to the front of it so that they don't worry about slipping in and taking out an eyeball. So there's two ways you can do this. You don't want this to happen. Nobody wants to slip on a cat. That space between the um, infraorbital foramen and the eye is minuscule, and one little slip and you're making a phone call that nobody wants to have to make. So I don't use this in cats very often. I actually use the caudal maxillary block the majority of the time because it is going to block all of the maxillary teeth on the side that it's administered on. And you're going to block that caudal to the second maxillary second molar, and it's going to get that infraorbital bundle. Now you have to use some caution because there is an eye there, but I've got some tricks for you. So again, I'm now blocking way back up here, and it's going to hit that entire nerve bustle. Okay. Excuse me. There's my nerve bundle. Okay. That's what I'm looking for. Now I used to kind of bring my needle kind of crosshatch over that first molar and go back in, and then I kind of straighten it out and go straight into that space. But then I learned this new technique, well, the newer technique for me anyway, and I love it. And I hope you will too. You basically bend your needle. It's the one time you get to bend a needle, right? And with your patient, either in dorsal or lateral recumbency, you simply take that bent needle and drop it directly behind your second maxillary molar. And guess what's right there? That nerve bundle. And it works like a dream. It is awesome. Now, depending on the size of the patient you have, you're going to have to determine how far you're going to bend your needle. So if it is a large dog, I will bend basically the entire needle of a 7/8 inch needle. If I'm doing a cat, I bend about a third of it. A medium sized dog, I might bend it at about halfway mark. Now, you aren't going to be able to rotate doing this, but you still want to aspirate. Okay. And you just simply drop right back down there behind it. It is an awesome way to place this block. You're not going to worry about really hitting an eye or causing any other issues with this block. But when it comes to the mandible, another one I rarely, if ever, do is the middle mental block. And it's because it's kind of a blind block. It again is only going to block my canines and incisors. And that middle mental foramen is usually at the rostral root or the front root, mesial root of the second mandibular premolar. And it can be almost impossible to feel because of the frenulum. And don't even try this in a cat, guys. I mean, realistically, that foramen in a cat is about the size of a pinhead, and you're probably going to miss it. Okay. So it can be difficult to do this. If you only have an incisor to remove, yeah, it's worth trying to do this. So some people come in straight in like this. I'm not a big fan of this method. Again, you just go to the edge of the foramen. Okay. Create your bleb and then remove your needle, digital pressure and elevation, and it's going to block it. I actually usually will use the canine tooth if it's present as kind of a stabilizer for me. And I go and direct a blind stick basically at the root of that mesial root of that second premolar, at the apex of that root. And that's approximately where that foramen is going to be found. Mandibular nerve block, again, is one of my favorites. It's the inferior alveolar foramen is what we're hitting. There's two methods, and there's intraoral and extraoral. Now, I honestly can fully say I have never done an intraoral mandibular block. And that's because when I learned to do blocks, I was taught that the extraoral was safer because I was less likely to numb the tongue and hit tongue tissue. Okay. But it is a subcutaneous approach. So it's going to block all of the mandibular teeth on the side that I'm administering it on. This is an example of doing it. It's kind of a blind stick to kind of go back and And where's that foramen going to be? And it's back there quite past the teeth. And I've just never done this. That's the foramen I'm trying to hit. You can't get into it. I mean, if you take the jaw off, maybe, but I don't think Mrs. Jones is going to be really happy with you if you do that. So it's something you're going to have to kind of come up, excuse me, to the edge of that foramen and go in. So this is kind of what I'm going to do. And I actually will have my finger in the patient's mouth, okay? And I want them at a surgical plane. I don't want to get bit. But we all kind of have that notch, right? And most of our dogs will have that notch. And what I'll do is have my finger in there and I'm going to kind of, you can see my finger wiggle through the tissue below the jawbone and where that notch is. Now, if you have a dog, sometimes the big pitties don't have that notch. You simply draw a line straight down from the animal's lateral canthus of their eye, and that's approximately where that foramen is. Now, you're going to say, well, you put your finger in there, silly, you're going to get stuck. I've never stuck myself because when I start doing the injection and the moving my needle, I actually take my finger and I move it kind of away. So I'm pushing all the tongue tissue out of the way while I'm putting my needle in. And then I bring my finger back so that I can ensure that my needle is where it needs to be. And I can feel the needle. And you actually get to scrape the bone with this, guys. You want to be right on that bone when you're doing this. And I can feel the needle and I can feel the blood being created. And that way I'm ensuring I'm on the inside of that bone and not on the lateral aspect. So I'm going to make sure I'm where I need to be. So there's just another example of what I'm doing. Seeing you can see it kind of coming up from the bottom. This is like the coolest thing in the world, guys. When you get your finger in there and you feel that needle and you feel that bleb, you know you're in the right spot. So once I've got that bleb, remove my needle, and I just keep my finger there. I say 30 seconds. Half time, I'm happy if I last 10 seconds, but enough to kind of help direct that medication into that foramen. So when I do those blocks, like I said, I'm going to do the 2 caudal blocks most frequently. Now, once I've gotten that done, the patient's procedure's been done, you've maintained them on less than 1% ISO. It's amazing. Everybody's happy. You want to make sure you're doing some kind of post-operative pain control for that patient as well, because it can be painful. All right. So opioids are great. You don't want to necessarily always send them home with a pet owner. Torb is really weak, so not one of my best ones. I remember, drawing up individual syringes with the correct amount of buprenorphine, and capping it so that my owners only had to spray it in the cat's mouth. Drug logs were always a nightmare, and we found out the cats weren't getting the drugs because the owner was afraid to do this. So then I actually compounded with a compound pharmacy and had it made into an ear gel, which worked really well. But now we have Zorbium. So that is a 3-day topical treatment that's going to work really well for our cats. If a patient's hospitalized, might want to keep them on a fentanyl CRI for a bit. Oops, sorry, wrong way. We can also do NSAIDs, and this is going to work for mild pain. Again, that's part of that multimodal, and you can use any of the NSAIDs you want out there. I'm not going to say you must use this one or the other. There can be injectable, they can be oral. Make sure that you watch for patients who have any kind of kidney or liver disease when you're using NSAIDs. We are finding, and you probably know this already, but gabapentin is really actually working quite well to help with our patients who have dental pain. So it is something that we can add to the mix is gabapentin to the patient. It can help inhibit that excessive pain. You do want to make sure you lower the dose if we have any kidney issues, and make sure your pet owners know that the patient might be sedated or a little unsteady because of the GABA, but it does work really well to kind of help keep our patients more comfortable. So just an example of a protocol is going to be blood work, that surgical safety blood work, pre-med them with maybe medetomidine or buprenorphine, give that propofol or whatever induction agent you have to effect, maintain them on ISO or SIBO, As soon as you suspect you're going to need a block, get it placed as quickly as possible. And then I usually found that 3 to 4 days of post-pain management was sufficient for our patients. Now, another thing we can do for pain management is the Assisi loop. Now, this is the loop lounge. They don't have the little carrier anymore, but they do have the lounge pads that you can get, and they can go in carriers for cats or for a dog to lay on it. And what it is it's targeted pulse electromagnetic field therapy that kind of helps reduce that inflammation for the pet. So just a real quick case study here is there was an 11-year-old neutered male, domestic long hair, presented for full mouth extractions because he had severe gingival stomatitis. They managed him for over 2 years on steroids, cyclosporine, opioids, and other things because he had refractory. In other words, the full mouth extractions did not really treat 100% his gingival stomatitis. He was in that 20% area that didn't get treated as well. Routine checks showed that he had continued inflammation and proliferation bilaterally in the caudal mouth. So treatment, they tried convenium, mirtazapine, Depo. They tried the whole realm of what they can do. And then they went and tried the Assisi loop 4 times a day for 15 minutes. Okay. And they found that within 2 weeks, the erythema was improving. Okay. He enjoyed time in the loop. He loved his catnip toy when he was there. And within 4 weeks, the erythema was almost gone. Okay. And the proliferation was unchanged, but the erythema was gone. At 6 weeks, he only had about 3 millimeters of that erythema present with the proliferation, and the cat was eating. He was gaining weight, and they were able to discontinue his medications. So basically, the summary of today's lecture, and I do apologize for all of the mechanical technical issues we had, but pain management is mandatory. I love a multimodal approach because we want to hit different areas of that pathway. Dental blocks are really inexpensive, but they're easy to master. Don't be afraid of them. I used to ask people how many people did blocks and how many people did um, gosh, my brain is going dead. The injection in the spine. My brain just went down on what that is. When they're administering pain meds, and half the room would say they would do the spinal injection, but they would not place a nerve block. And I'm like, wow, blocks are so much easier, dental blocks. But the benefits of pain management far outweigh the risks that are associated with that analgesic administration. If anybody's interested in becoming a VTS in dentistry, you can go to abdt.us or just join the Foundation for Veterinary Dentistry. You're going to get a journal every month. You get to come to the dental forum, which is at the end of September in Palm Springs this year. A great time, 3 full days of dentistry nonstop. Or you can follow me on Beyond the Crown Veterinary Education. You follow me on Facebook or go to btcveted.com. I have a lot of 1 to 2 minute videos that go through all of this stuff we've talked about and other topics. And I want to thank you for your attention. So I'm going to open it up for any questions at this point.